I'd now like to introduce Dr. Jonathan Perlin, who is President of Clinical Services and Chief Medical Officer of Hospital Corporation of America, or HCA. He provides strategic leadership for clinical services and continuous improvement of performance at HCA's 170 hospitals and 168 outpatient centers. Current activities include developing and implementing electronic health records throughout HCA, improving clinical core measures to benchmark levels, and implementing advanced patient safety programs, including efforts to eliminate preventable drug-resistant healthcare-associated infections. Please join me in welcoming Dr. Perlin to the podium.
Thank you for the pre-op briefing. Good afternoon. It's great to be here with you. Really just such a pleasure to be here and hear about the great progress in the Commonwealth of Virginia. In many ways, I feel like I am home. I have not lived in any other city longer than I've lived in Richmond, and it's just such a wonderful opportunity to come back and reconnect with so many friends and colleagues. I've lost count. I think I may be either a 6 or 7 times alumnus of VCU, and obviously a great affinity for the university, and Sheldon Retchen, Dick Wenzel, and others who are just great mentors to me, and Margaret Lewis, who runs the Capital Division of HCA. Has also been a longstanding friend, colleague, and mentor. Great to see Ann Ladstetter. And the problem with naming names is that you will invariably leave someone out, but just today to reconnect with Sally Cook, her great leadership in the QIO, Johnny Wong, longstanding friend Dick Grinnan, and Barbara Baldwin, and others. Really do feel very much at home. And it's good to be home. But it's also a privilege to learn from you and take back many of the great stories we've heard today. I want to start with a story. I saw in the program, and a little embarrassed that it came out that way, but obviously good research was done. It says the Honorable Jonathan B. Perlin. Well, that honorable is usually usually dispensed with, but legally you're entitled to use it if you have been elected to office or if you were nominated by the President and confirmed by the Senate. Indeed, I was. In fact, there was a period where I was CEO of the U.S. Veterans Health System, and it is the senior-most position in the federal government. Nevertheless, I was not empowered to assure that my own mother had care with the attributes of safety, effectiveness, efficiency, and compassion that one would want. And I mention these words because I think the goal of healthcare really should be to deliver care that's safe, effective, efficient, and compassionate. And I think we meet that test when we're able to do that without the need for an advocate. So what happened? Well, my mother had a minor surgical procedure, which received general anesthesia at a very name-brand institution. No retiring individual, very forceful personality, etc. When she woke up from anesthesia, I said, "Mom, how are you doing?" I said, "Well, I'm fine now." I said, "What do you mean?" It's my heart sunk. I said, "Well, I know when you trained in medicine and when your dad trained, you didn't really wear gloves to put in IVs. But times have changed. And when the anesthesiologist put me to sleep or put in the IV, he had blood on his hands and under his fingernails. But I didn't want to say anything because I knew he had my life in his hands." Well, that really helped to formalize passion around infection control. And I want to talk about some opportunities that are fairly specific in a national program that the HCA has undertaken to really help empower patients to be able to assert, to demand that sort of infection control that any patient deserves. And so I want to talk about that in terms that frame the new business case for safety. In fact, some of you might think at the end of this that the CFO is your new best friend. And indeed, the CFO is now on the side of quality because healthcare is moving toward value-based healthcare, and that means good, safe outcomes are the most financially productive outcomes as well. I want to talk also about simplifying the science and indeed all of my mother's experience using the patient or working with the patient, empowering the patient to drive change. So let me start with the conclusion first, that value-based healthcare really provides the backdrop, the emerging business case for safety. And this can be used, if we use this, we harness this energy as constructive tension for creating improvement, because good quality then becomes good business. Sometimes the science is confusing, and sometimes we talk ourselves out of what might be most productive to do. And I want to talk about how we created an ABCs program to simplify that science, package it, and really drive change in our hospitals across the country. I talked a little bit about the importance of empowerment, but the frame of reference is also important. It's not just good enough to be better than average. One should suit in the area of infection control for zero tolerance, eliminating infections. If we flesh that out a little further, you see that CMS, you know that CMS has introduced the concept of not paying for things that should be avoided, hospital-acquired conditions, and indeed many of the payers here as well have removed reimbursement for events that should not occur. And that is really a fundamental underpinning. And the opportunity to take that science and package it for different audiences to help our financial colleagues understand that good care is good business is really an opportunity to create an accountability for clinical outcomes across not traditionally clinical venues who can become increasingly interested and facilitating in driving improved clinical performance. Well, I want to put in context how high the bar is in terms of value. We get on a plane, we think nothing of bad things happening. Aviation safety is far better than bad things happening 1 in a million, 1 in 10 million, even approaching 1 in 100 million. Now, the mythical Six Sigma is a failure rate of 3.4 per million. Anybody here lost a bag while traveling? I see a show of hands. Folks in the front, look back. Maybe I should have asked, is there anyone here who didn't lose a bag? Well, I had to move the failure rate down from 1 in 10,000 to 6 in 10,000 over the last 5 years. Sorry about that. But I think we'd all agree that's not satisfactory performance. However, if we compare that to the rate of a drug that can reduce your chance of dying after a heart attack and reduce your chance of a second infarct by 43% in the first 6 months, and by the way, save $20,000 in avoidable excess healthcare expenditures, I'd say we want that not only as much as we want baggage handling, but more like the aviation safety. Indeed, when we talk about rates of 99%, that's half an order of magnitude lower performance than baggage handling. When we look at immunization, it's a little bit lower still. It's actually a rate of 2 out of 3. And if we look at issues like hand hygiene, you know where that's coming on this chart. So stop me when I get to the rate that you think is right. Physicians in academic ICUs, as observed across the country, wash their hands 60% of the time, 50% of the time. Do I see any 40s? 30s? 20s? Well, there it is. And this is data that was generated by investigators here in Richmond. Dick Wenzel, Mike Edmund, Werner Bischoff, and others showed that outside of surgical procedures, physicians in academic ICUs across the country, before and after patient contact, wash their hands for the surgeons, 3% before patient contact, 9% afterwards. And as an internist, I can hardly be proud of the fact that we were twice as good, 9 and 18% respectively. Well, we've got problems. We're not doing the things that we should be doing. Beth McGlynn's work shows that evidence-based measures of care for prevention, for management of chronic disease, are only performed about 55% of the time, and we have an epidemic of underuse. We also have an epidemic of overuse, also impairing value. That's a normal distribution of the rates of cardiac stents across the country, and you see that that there is an outlier, Elyria, Ohio, which is a wealthier suburb outside of Cleveland. Do you think there is a scientific or medical reason that cardiac stents are used 5 standard deviations more frequently than the neighbors in Cleveland? Or do you think there might be something else going on? As the health services researchers learned, they quipped, well, what do you call someone without a stent in Elyria? Answer, a visitor. Ouch. Well, there's opportunity to improve the value in terms of things that should happen, things that shouldn't happen as often as they happen, and we don't have to look very far to find that we have an epidemic within healthcare itself. We always talk about the 98,000 patient deaths per year because of avoidable adverse events, but did you know that there are 1.7 million avoidable healthcare-acquired infections in the United States that result in at least 99,000 deaths, more than the total of motor vehicle accidents, breast cancer, and AIDS combined. We have an opportunity to improve healthcare. Well, we have an opportunity to improve value, and this is where the business case for quality and safety really begins to become apparent. One of my mentors, the late John Eisenberg, used to have a very interesting way of saying, what would the naive observer think? Well, they'd say, in a fee-for-service system, the more you do, the better you do. The economic incentive is directly related to volume. And we know that is changing, that we're now moving toward a value-based health system, accelerated by the economic pressures of the moment that is the relationship of quality or performance to the resources invested. And the new paradigm becomes value-based purchasing and value-based insurance design, moving care to those providers that consistently provide better, safer care more efficiently. In fact, that model allows for volume growth, access to patients, even premium pay, and the new incentive is sort of the better you do, the better your access to volume growth, patients, premium pay, the better you do economically. One fundamental formula for that is, of course, pay for performance, but it's really just a subset, and it's obvious there, the better you do, the better you do, or under the new CMS rules, it's really non-pay for non-performance. Unless you hit the 75th percentile of performance, you don't get full reimbursement. And Senate Finance Committee, Max Baucus and all, put out the note that they were considering 5% holdback. And Kathleen Sebelius, just a week ago Friday, put out the announcement that no, they're considering 15% holdback. Well, whatever it is, the message is very clear. This horse is not going in the barn, and there is not adequate satisfaction with the quality of care. Now, let's move to the things that shouldn't happen. And it's pretty clear CMS has really set the direction with the hospital-acquired conditions, saying that things that should not happen, that are highly preventable, will not be reimbursed. Let's move now to talking specifically about infections and the epidemic of infections. This chart shows the breakdown of the major categories of infections. Surgical site infections, about 20%, bloodstream infections, about 11%, obviously the big, large yellow chunk there, UTI, and pneumonias. And if we look at the causes of infections in the hospital, you see that that MRSA, Staph aureus, comes up as one of the leading in both the central line-associated bloodstream infections, the ventilator-associated pneumonia, and in the surgical site infections, as you might expect, and overall, one of the most prominent infections. In fact, if we go and look specifically at the mortality associated just with one form of Staph aureus, MRSA, we find that, according to Cleven's work, that 19,000 Americans died in 2005 in hospitals because of healthcare-acquired MRSA. Big chunk of that death rate. Now, Association of Professionals in Infection Control identified that essentially 1 out of 20 patients in hospitals is carrying MRSA. And we know that MRSA is becoming more prominent in the community across all populations. And I'll come back to that momentarily. But we know as well that we're in an environment where we can use some of the environmental forces to really focus our attention on these preventable events. Well, if some of the quality measurement is somewhat arcane and really only understood by employers and human resources office, I think patients really get this one. If you took your car to the shop, happened to be a Lotus Elise, and it fell off the lift, and they said, you owe us $800 for the tires and $8,000 to fix your car because we dropped it, you'd say, what are you smoking? Well, I think Herb Kuhn, former deputy director of CMS, said, a woman shouldn't come into the hospital, deliver a baby, and leave with a broken arm. Consumers get this one and are really outraged that there was even any reimbursement for things that were highly preventable and went wrong. And of course, 10-108, 11 conditions went into place that were considered to be highly preventable, and the majority of those, among any particular group, had to do with infection control. Now, we can argue about the nuances of preventability, or we can actually figure out what we're going to do to control events over which we have opportunity. Now, let me start with the business case. Meredith Rosenthal actually put together a study of the New England Journal of what the typical Medicare reimbursements were for 8 of the initial highly preventable conditions. She left it blank in the central line bloodstream infection, but I'm going to fill that in for you, and you can see that in each of these areas there are substantial dollars that were offered back because of these now known to be highly avoidable complications. And in fact, if one looks specifically at central line infections, this is the work of Shannon, you see that the additional excess costs are $92,000. And when CMS would used to provide some support, that was $65,000 of the pain taken away. Now, I say that somewhat facetiously because, of course, that pain pales in comparison to the pain of the patient who's forever affected by an avoidable infection, perhaps with life-threatening complications, perhaps even with threat to their life or loss of life. Well, the loss, quote, only used to be $27,000. Of course, without that, now it's $92,000. Every one of those cases that's avoided goes straight to the bottom line. Good quality, good safety is good business. Well, not all healthcare-associated infections are central line bloodstream infections. Sometimes they're just routine healthcare-acquired infections. And again, in a study done by researchers Allegheny and Barnes Jewish Christian in St. Louis, looking at over 1.5 million patients, they found that the average cost, excess costs, associated with healthcare-acquired infections were $5,018. Well, these were never break-even. They were certainly never profitable, and if some thought that the pain economically or financially went away with that complicating condition reimbursement, here's news, myth busted. I'm sure many of you in your work get the question, well, gee, these are hard to even with our best practice, it's hard to control, it's not fully under our control. Sometimes central lines just auto-inoculate and the infection just happens. Well, in the last discussion, there was discussion of the Keystone Project, and so I'd suggest now that really is the wrong question for two reasons. I think the real question should be, even if we debate how much is under our control, are we doing everything within our control to prevent highly avoidable complications? And oh, by the way, I would have to change my stance pretty dramatically based on those Keystone data that show greater than 18 months mean time between avoidable central line bloodstream infections. Now, I don't want to minimize how complex this is, and I think the last speaker was just right on point that the conversation between the nurse and the physician is tremendous. I think that checklist is incredibly empowering, doing a little research into understanding how it empowers nurses to turn to a physician like me and say, hey, Dr. Perlin, I know you put in hundreds of central lines. I know you never swing that pulmonary artery catheter, but just humor me. Why don't you drape the patient beyond his thorax or her thorax? And that's all that checklist is full body barriers and washing with chlorhexidine and the permission to intervene and change the dynamic is really what's at work. Well, this is complex. These are the drips for a single patient in ICU, an individual with obviously a life-threatening disease, and any one of those can be a route of entree for an infection. But we have a problem. If we look at sort of normative performance, we might be comfortable with a moderate rate of infection control. On the other hand, if we look at some world benchmarks like Denmark, where they don't have cases of MRSA anymore, essentially, you might ask, what are they doing that we're not? Or in the VA, or up at the unit at Harvard, all of which identified a bundle of activity and a number of common threads that seem to be associated not with doing better than the average, but with really achieving and moving to that mythical performance level of near perfect performance. Well, what do they include? Screening high-risk patients with active surveillance cultures, use of barrier precautions, hand hygiene, standard precautions, patient empowerment, and leadership accountability. And so we took that world literature and synthesized it into A, B, C, and D, and I'm going to walk you through these ABCs, which I hope are highly memorable. A is, of course, active surveillance, and we do across our system is targeted active surveillance, where we screen patients at high risk for carrying MRSA, and it's well known that these are individuals who've had repeated experiences with healthcare, and I'll come back to that point, as well as patients who are at high risk for a very bad outcome from getting MRSA. So we try to identify. Now, who are patients at high risk for a bad outcome? Did you know that among patients who have hip or knee replacements or who have a bypass surgery, when there is a post-operative infection, 50% of the time today, according to the CDC and John Jernigan's work, it is MRSA. Well, we know what staph infections, fulminant staph infections look like, but what about patients who are carrying MRSA? What do they look like? Well, of course, the patients who have the visible infection are just the tip of the proverbial iceberg. The bulk is in the great mass, and those individuals look just like you and me. The rates of carriage of MRSA in the community are substantial. 1 in 3 Americans harbor staph, and 1 in 3 of those, essentially 11%, are now carrying MRSA. What's particularly compelling, if one looks at school-aged children, a decade ago, those numbers were a tenth of that, so a tenfold increase in school children in both urban, rural, and suburban populations across the country. So you also see from the slide the great majority of MRSA is really healthcare associated, but most of that healthcare associated is spread person to person in the community. Well, how does the literature help us in terms of this pretty controversial topic of screening for MRSA? Well, it's tough because the recommendations once were very strong by MSHA, and they said absolutely do active surveillance, and then they sort of backed off from that. There was a political schism. And the CDC says, okay, you can use that when everything else fails. And if you look at the more recent literature, you see very strong studies that show, oh, no, it didn't do anything in a Swiss hospital, or it worked in an American set of hospitals. Well, I think the CDC guidance is pretty good. If you've tried other modes of eradicating MRSA or other infections, then the opportunity to use. I mentioned the rates of hand hygiene in academic intensive care units. Another important point in the study was that if you increase the rate of hand sanitizers from 1 to 4 beds to 1 to 1 bed, you actually increase the hand hygiene compliance by 20%. So this seems like a very important point. If you can increase the number of hand sanitation stations, it's exceptionally powerful. Well, this is not a new concept. Ignaz Semmelweis in his clinic actually discovered that those nurses who washed, or nurse midwives who washed their hands between clinics had half the mortality than the physicians who didn't wash their hands. The intervention, lime water, or essentially a form of chlorine. And when everyone began to do that, you see the two clinics, which had very different mortalities, converged. Essentially, that was the beginning of germ theory, and we would have expected a culture change that has occurred in the food service industry, on cruise ships, and maybe we can get to that level of cultural awareness in our own culture. So we have letters that we write to patients on their admission and their families. An honor to care for you. Please help us in keeping you safe, keeping your family members safe. Take advantage of these hand hygiene stations. Wash your hands. And remember, you're welcome to remind your caregivers or ask your caregivers if they wash their hands as well. Well, the rates of hand hygiene have gone up and been sustained 350% since the program began. Let's talk about disinfection. We've gone to pictographic instructions. Why? Because some of the instructions prior were somewhat less than transparent. For terminal sanitation of a room, use a cleansing agent with strong alkaline characteristics. Let it dwell on the surface for not less than 30 seconds. Do you know what that means? Use bleach. That's been translated to a pitcher, bleach, sweep of a clock for 30 seconds, and arrows to all of the different surfaces that should be sanitized. E is executive ownership, and in addition to patient empowerment, but the executive ownership are a number of to-dos to really get with this program. And here is the response. Across our 163 hospitals, 5% of patient care, major patient services nationally in hospitals, essentially a 24% reduction in surgical site infection, in bloodstream infections, a 35%, one-third drop in bloodstream infections, and over half, 50% drop in ventilator-associated pneumonias. Now, I'm going to go back to the literature again, and here again are the costs of catheter-related bloodstream infections approaching $100,000. Ventilator-associated pneumonia studies have been summarized, if you look at the right-hand side of that chart, at $80,000. So in addition to those substantial decreases, your CFO is your new best friend because each of those went straight to the bottom line. Good quality is good business. Now, the elements of the toolkit are available in the public domain at the HCA website. I invite you, if they're useful to you, to take advantage of the visitor cards, the ABCD poster, the posters at hand sanitation stations, and the static clings that are fully available, and in different languages as well. What have we learned? We've learned that this is tractable, that the benchmark really should be zero tolerance for avoidable infections. We've learned that we can identify with active screenings patients at high risk. In fact, we know that 1 in 10 patients, 12% of patients that we screen are positive, and that is diluting not only the patients who have had a lot of healthcare experience, nursing home admissions and the like, by patients at high risk who haven't had lots of healthcare experience. We know there are concerns about the liability of not knowing about MRSA and the liability of knowing about MRSA, but the right thing to do is to know and to treat. And you might think, gee, you're dwelling an awful lot on MRSA. What about all of the other infections? C. diff, vancomycin-resistant enterococcus, the extended spectrum beta-lactamase-producing organisms, etc. Well, the evidence is, even if you villainize MRSA, you get this compounding effect on all of these other infections. Work out of the VA shows that VRE and ESBLs all went down. Well, MRSA's been in the news a lot. Received a lot of questions and a lot of concern among parents calling in and asking about what they can do to stay safe. And obviously that's not the real issue. The real issue is good hand hygiene is good infection prevention. Well, whatever credibility a middle-aged physician might have, it pales in comparison to, say, the teen star of Hannah Montana, Mitchell Musso. And so we partnered with Mitchell Musso to help kids understand the importance of hand hygiene. And the message was that through this process we could really keep kids healthy in school, teachers healthy in teaching, and parents healthy at work. And if we might, let's take a quick look at this 30-second video.
What's up, guys? It's me, Mitchell Musso. We all know how easy it is to get messy, goopy, gross stuff on our hands. Like doing chores at home, playing at school, and especially when you sneeze. Yuck. That's why it's important to always wash your hands. Germs can make you sick. So wash your hands whenever you can, and not just before you eat. And remember, clean hands are cool hands, so let's wash up. See ya.
Check out more of Mitchell at cleanhandsarcoolhands.com.
Well, Mitchell has really helped get this message to kids. In fact, this thing went sort of viral, to use a bit of a metaphor, and it's now had over 50 million hits on the website. And the message has been particularly important as we've been thinking about the epidemic of swine flu. Well, that's part of the broader message of infection control and empowering patients and empowering communities to really put this in their own hands. I want to close by talking for a moment about C. diff, because Clostridium difficile infections really are the infections of our time. Clostridium difficile has becoming increasingly prominent, huge increases in both morbidity and mortality, but also, once again, excess cost. 8.7 days excess length of stay, $8,000 additional excess admission. 10 to 35% of healthcare-associated diarrhea is C. diff, and it's frequently associated with overuse of antibiotics, and so antibiotic stewardship becomes particularly important. And in addition to better infection control, it's also an incredible opportunity for better patient outcomes. Critically important because there's been over a 400% increase in C. diff mortality in the last 5 years at home. Well, what's the intervention? It's virtually the same, except soap and water instead of alcohol-based hand sanitizers to eradicate this. And so the ABCs are going into round 2 with the A moving from active surveillance to antibiotic stewardship. And you see the elements and can refer back to those later. Well, it really is in our hands. And the truth of the matter is that we can't buy enough gowns, gloves, masks, hand sanitizer for this not to be a very strong positive return on investment, a return on quality, a return on safety, and the very best for the patients. Well, we believe this value-based healthcare approach is really the future. I want to commend my colleagues in the Capital Division of HCA on some of the QHIP this year. 7 of the top hospitals, top 10 in Virginia, were really just hitting the performance measures on that. And we're pushing beyond trying to eliminate errors to learn not from the crash, but from the near miss. And as part of a learning health system and part of a learning community, which is really so well represented by Virginia with this great and incredible tradition of this program, Virginians Improving Patient Care and Safety. So I hope these resources are useful to you. Again, all in the public domain, all available for your adoption in any way that's helpful. But I hope it also gives you not only some clinical information, but a good business case to go back and discuss with colleagues why good quality and the best in patient safety is good business. And so that your family and my family can get care with the attributes of safety, effectiveness, efficiency, and compassion without the need for us to be advocates. Thanks so much for everything you do and your great leadership. Thank you.